Good morning, everyone. Welcome all to this morning's Pediatric Grand Rounds. This is the 30th annual James Suber-Buehler Lecture. And we're gathered once more honoring Dr. Suber-Buehler. We were very saddened in fall of 2019 with his passing. And every year we gather to remember his legacy and bringing one special Grand Round speaker from all over the world to share their research and contributions to the field. And for some of you who may not remember Dr. Suber-Buehler, I would like to just spend a few minutes going over his history and extensive contributions to our field. So Dr. Suber-Buehler was a local. He went to Allegheny College and then obtained his medical degree in Philadelphia University of Pennsylvania. In those days, there wasn't much of pediatric cardiology training as such. So internal medicine residency happened at Penn, and then he did a cardiology fellowship in adult cardiology at the University of Michigan. Then he served in the military for 2 years, tour of duty in the Air Force. And as trained, although he trained as an adult cardiology physician, his passion and calling was for the understanding of congenital heart disease. Here's an interview with the Pittsburgh Post-Gazette, and he was saying heart disease in children is usually congenital defects, and there are hundreds of different anomalies, hundreds of combinations. It is like putting together the pieces of a puzzle. That proved very interesting and challenging. As an adult cardiologist, you're just dealing with blood pressure, coronary disease. Well, it's interesting, didn't seem nearly as interesting as congenital heart disease. So I made a great choice and have no regrets. I had a great career dealing with kids. I think we all share some of that, passion for all those challenges that these kids pose to us. He had a significant medical legacy. It was tremendous. He joined Children's Hospital in 1963 at Pittsburgh, and then he became chief of cardiology and was chief of cardiology from 67 to 94. That's a long time. He was acting chair of pediatrics from 87 to 88 as assistant children's hospital medical director from 82 to 94, children's medical director for 2 years, and then vice chair of the Department of Pediatrics from 88 to 94. He was also serving the board of Children's Hospital and a member of executive committee. And he trained and mentored an entire generations of medical students, pediatric residents, pediatricians, and cardiology fellows. Here is one of the original pictures from the pediatric cardiology, from the cardiology team at the time. You can see a doctor here, a younger version of Dr. Bierman here. And there's Dr. Park, Dr. Suber-Buehler here, and many of the, who built the field here in pediatric cardiology here. And you can also see him enjoying playing some golf with Professor Bob Anderson, who used to spend a lot of time here in Pittsburgh, and they were close friends. He was really a master clinician and an incredible diagnostician, and he authored also a textbook on clinical evaluation on congenital heart disease, an amazing teacher in terms of his clarity, intelligence, and brevity, to the point. He was free of pretensions, and his sense of humor and warmth endeared him to his students, colleagues, patients, and their families. He had a great approach. Don Thomas was a nurse who worked in cardiology for 19 years and said he reminded me of an old country doctor because he was very down to earth, very comforting talking to families. He never put himself above the level of the families. He made everybody feel very comfortable. And really an incredible contributions in terms of scholarly work and contributions to our field, very many seminal articles of congenital heart disease. You go to a very early contribution on Epstein's anomaly here from Pittsburgh, and then the trilogy of Fallot, postoperative EP studies, Epstein malformation, some more, morphology of ventricular septal defects associated with coarctation, and many, many more, heterotaxy, like really extensive contributions. And these papers, many of these, an extensive number of are being referred to in the future in so many years thereafter. He also really loved the high altitude. Not only he did research on high altitude, but he loved skiing and being in the mountains. And there he's with Dr. Sang Park. And he established that culture that he brought. I think is something that we enjoy today. We can proudly say that we stand in the shoulders of giants based on all the legacy that Dr. Superbuehler brought and the culture that he created in the cardiac program here in Pittsburgh. I also wanted to let you know that he also contributed to the botany, and he has these beautiful description of 900 species of wildflowers in Western Pennsylvania that you can find online that he did, which is wonderful. And he lived in Beaver County, and that's where he was born in 1929. And here's with his horse, and there's a little book that lists a lot of Pittsburgh locals, and there's Dr. Superbuehler. So every year we honor Dr. Sub with Pediatric Grand Rounds, and you can see it's a long list of very significant contributors to our field that have come to Pittsburgh. And this year we have the great honor of having Dr. Vibeke Hjortdal coming all the way from Denmark to join us. She's professor of cardiothoracic surgery in the Department of Cardiothoracic Surgery in Copenhagen University. And she graduated in 1988. And then she also did a PhD, and she specialized in thoracic surgery. She trained in Great Ormond Street. And then CT surgery was a CT surgery professor in Aarhus University. She was head of heart surgery for the essentially whole western part of Denmark for many years. She amazingly was knighted by the Queen of Denmark, so that's really amazing. And she also then has moved to Copenhagen and has been professor there since 2019. An extensive number of contributions to our field, more than 400 peer-reviewed publications. She really works on the pathophysiology of congenital heart disease, especially interactions between the heart and the lung. Incredible contributions in terms of long-term outcomes of congenital heart disease, lymphatic function, and also interest in neurodevelopmental outcomes. And really has done work in basic science, really translational research, and also clinical and epidemiology. So it's a great pleasure to have Vibeke here with us today. So Vibeke, welcome. She's going to be talking about congenital heart disease long-term outcomes, data from National Danish Registries.
Can you hear me? Can you hear me? Yeah. Thank you, Jackie. Thank you very much for this introduction, and thank you for the opportunity to come here and talk to you today. It's really a great honor. And when Jackie sent me the list of the previous speakers, I was starstruck. It's all the people I've admired over many years, and now I've added Dr. Superbuehler to my list of people I admire because I got to know a little bit more about him by reading about him. And I think it's what you said is we all stand on the shoulder of giants. We all build on the knowledge we have from the people before us, and we really should acknowledge them the best we can. And I think this is a fantastic way to acknowledge a grand mind, is to make a grand round in his name. So thank you for that. Professor Kreuzer gave me the job to talk about the Danish registries, and that's because she's been visiting us in Denmark twice, being an opponent on some of my PhD students when they had to defend their PhD thesis. So she had seen how we try to use Danish registry to get more information about patients with congenital heart disease. I know that some of you are not dealing with congenital heart disease, so I've tried to make this presentation more, you could call it generic, try to hopefully make it so that some of you who are interested in other fields could also think about how registries could be used. So I will, in this talk, go over this list of subjects, and I think you can see that pertain to most things we deal with as doctors. When we look at our patients, we're interested in outcome over decades, mortality, morbidity. Psychiatric problems is something we see in a lot of our patients with chronic diseases. We can look at how our patients are doing in terms of being able to get a job and retain a job. education is something we can look at, and I will also talk a little bit about the risk of self-harm and suicide, the fertility in this group of patients, and how the maternal fetal environment impacts on congenital heart disease. And I know that there's tons of good literature out there, and there's a lot of literature that has much higher impact than the literature I'm going to present today. But since it's based on the Danish National Registry, I will primarily talk about the papers we have made. And it's not out of arrogance, it's more practical. So Danish National Registries, we can use it to see how we are doing over time, to see changes over decades. So on this curve, you can see all the patients who have been operated for congenital heart disease before the age of 18 since 1977 in Denmark. It's about 10,000 patients who have undergone about 12,000 either cardiac operations or interventions. And on the graph, you can see how they do if they have a complex congenital heart disease in terms of survival. So what you can see here is that the top curve is the background population surviving to the age of 40 with almost 100%. And then you can see the three curves representing different decades. The lowest curve is the poor survival of the patients we operated on in the 70s. And the top red curve, the short one, is the survival rate of those we operated on in this millennium. And this is great. We can see that we have improved the care for our patients over the years. It's something we also know from a lot of other studies around, that we are getting better and better. We can also see that we still need to improve further in terms of having more of our patients survive. So there's still a lot to be done. You may have wondered about the number of patients. I was talking about 10,000 patients is basically nothing. I mean, I think it corresponds to half of you have operated in Pennsylvania or something like that. But you have to remember that Denmark is a very small country. We are about 5.7 million people spread out of Denmark, the Faroe Islands, and Greenland. And every year we have a low birth rate, so we only have about 50,000 newborns every year, and about 1% of those have a congenital heart disease. So it's actually only 500 new cases every year. So it's a very small country. This is our king and our queen saying hello. So, yeah. So, but it's not all patients who are operated we are interested in. Basically, what I've been looking very much at in the last years are patients who do not undergo surgery. The patients that have a congenital heart disease where we think it's too small to do something about it, hemodynamically insignificant. And then we look at how are they doing in the long term. So if you take the most common of the congenital heart diseases, the ventricular septal defect, you can here see how they are doing in terms of survival over many years. Here we have looked at patients since 1959, and we can see how they're doing in terms of long-term survival. And the majority of these, 9 out of 10, would be patients who were never operated on. The VSD was found, they were discharged because it was not a large VSD. When we follow those patients up until the adulthood, you can see that their mortality rate increased when they are beyond 40 years of age, and they have on average a 10 times shorter lifespan compared to the background population. Some of you who know the literature may say, well, we have seen other VSD papers showing equal survival over years, so the natural history is probably not that bad. But you have to remember that these papers like Hjortdal's, Gabriel's, Engelfried, and Muller's paper talking about VSD, they all ended at the age of 40, around 40 years or before. So, and in our cohort, we can all see there's no difference when you look up until 40 years of age. But when you then follow the patients further on, then they have an increased risk of dying early. You may say that those who are more than 40 years old, they belong to a cohort that was treated completely different from how we treat patients today. And you're absolutely right. Today we operate early on. The risk of surgery is smaller. So of course the patients we operate are doing better today than they were in the 70s and the 60s. But remember, the majority of these patients never had an operation. these are patients that we just left with a small VSD we thought was insignificant. VSD is the most common, but we also have what we would consider in our field the most benign of the congenital heart diseases, a hold between the atrium, the ASD. And here you can see the survival of ASD patients. So you can basically see it's the same story. They do very well until they're about 40. Then the survival starts to decline. And this is the sub cohort who are not operated on. You can see the survival curves start to separate in the 30s and early 40s. So they have an increased risk of dying before the rest of us. So 50% of this cohort was dead at the age of 65 years. So you can now say, should we, based on these information, should we close more of our ASDs and VSDs? And to that, I have to say, registered data cannot answer that question. We can only show you a picture of what has been going on. We cannot use these data to definitely tell the story about whether we should close more. But of course, we can hypothesize it may be a good idea to look at it. And I basically think with all the improvements that has been now in treatment, and especially the fact that ASDs are now closed primarily by Jackie and not by me, then I think it's time to do a randomized controlled trial and look at some of the patients that we would normally consider too small to need a closure. Because the criteria, when we made the criteria, it was based on the alternative being surgery, which had a risk. But nowadays, the risk of percutaneous techniques is so small. So I think it would be ethically good to do a randomized trial to answer the question, should we close more of these small ASDs and VSDs? Good. So registries can be used to look at outcome and mortality. But of course, you also know that before mortality, you have morbidity. So what is causing death in this group of patients is really interesting. And I can see that we probably only see the tip of the iceberg because we treat patients at different stages in their lives in different units. So peds look at the children and adults look at the adults. And sometimes we don't even talk about, here you have a good collaboration, you talk to each other, but a lot of places, the peds never know how the adults are doing because they never get the feedback. So I think we can see in our registered data that there's an underappreciated burden of heart failure, arrhythmias, infected endocarditis, and pulmonary hypertension in this group of patients that we have looked at. So we use the national registries to disclose the problem and then hopefully bring this information back to the people who see these patients early on. So maybe they can think of, could they change the way of treating these patients? So if we look at lifetime burden of morbidity in patients with a VSD. So here we have 9,000 patients with a VSD, and we have found 90,000 controls in the background population matched on age and gender. And then when we look at how many patients were admitted to a hospital or seen in an outpatient clinic who got a diagnosis of arrhythmia, and on the left part of the graph, you see the ones who are not operated. On the right part, you see the ones who were operated, and the curves show the comparison to the controls. And you can see a much higher incidence of arrhythmias in patients who had a VSD, no matter whether they were operated on or not. You can also see that heart failure is something that they deal with in adult age, just based on information about how often do they see hospital for this particular disease. And you can see that it starts around 40 years of age, then they really start to be bothered by their heart failure. That was VSD. ASD, the same. I mean, these are the two most benign congenital heart defects we have. I haven't talked about the complex one, which I think is probably even worse. So if we take the ones who have a small open ASD thought to be unimportant, then 31% will have arrhythmias after 20 years after being diagnosed. The ones we have closed surgically or percutaneously, it will be 21% will have problems with arrhythmias, so much problem that will be admitted to a hospital or seen in an outpatient clinic. And these are very high numbers. For those of you who are not in the field, I can say that the background population in Denmark, you will have 9% who have atrial fibrillation at the age of 80 years old. So it's really a huge difference we have here. Stroke is also something that we sometimes see in our patients occasionally, and we can see that the hazard ratio for having a stroke when you have an ASD is increased, and part of it is because they have very often atrial fibrillation, but when we adjust for that, it's still a higher incidence of stroke in these patients. When we have closed ASD, we can decrease the incidence of stroke in these patients, and basically, this looks as if you can get rid of the hole and you can get rid of the atrial fibrillation. They do not have an increased incidence of arrhythmia in this cohort. So national registries, we use it for that. We have also used it to look at the next part, which is the psychiatric burden and work participation for our patient. These are two very important aspects of life, that you can be free of psychiatric problems and that you can participate in work life is important for a lot of people. When I've talked about these two aspects, I'll tell you about how these national registries are working, because you may start wondering, how does it actually work? So psychiatric comorbidity and work participation. Morbidity is much more than cardiac morbidity also in our patients. And I think it also goes for a lot of other patients with chronic diseases, that this is a huge impact on people's lives. We've looked at the registry to see how many got a diagnosis of a psychiatric disorder. And it's, since we are looking over a long span of time, the way you diagnose and the way you give diagnosis changes over time. So there's lots of different ways you can group psychiatric disorder, but in order to kind of cover the whole time period, we have chosen to use this classification. And you don't need to kind of look into the specific type of classification. What I want to show you is that patients with congenital heart disease have problems in all aspects. It's not like it's just one, it's all aspects of these types of psychiatric disorders. We can also look at how much are they bothered by looking at how many of these patients get a medicine for their psychiatric disorder. And here you can also see, compared to the background population, there's a higher frequency of being on psychiatric medication. Another way to look at it is to look at time of life when you start to have your psychiatric diagnosis. And here I've taken our group with the atrial septal defect again to show that the psychiatric diagnosis that they have been given are given in quite early age. You can see some of them is even around 20 years of age or before. And the very interesting part of this is that this cohort of ASD patients, there were quite a lot of those who were diagnosed with their ASD in adulthood and then had their ASD closed. So quite a lot of the psychiatric disorders were diagnosed before they even know they had a hole in the heart, which I think tells us something about it. It's not just, the knowledge about being sick that makes you have psychiatric problems. It's something much more profound. And I think there's also more and more evidence that some of these psychiatric problems are grounded in much, much earlier, even in fetal life. So in order to kind of get further on, I mean, these registries can give us an idea about some associations, but they cannot give us any clear answers. But in order to try to look more into this, what is the reason for these psychiatric problems in a group of patients that we basically think should live a normal life? So we now started a genetic study looking at 80,000 Danish patients with a psychiatric diagnosis and 50,000 randomly chosen patients from the background population. They have all had genetic testing. And now we're trying to see if we can find a polygene risk score to see, is there something genetically that kind of, you could say, code for both a psychiatric problem and a congenital heart disease. See, the thing about having a work is is very important for a lot of people. That's where they feel they are part of a society. They can go to work, they can participate to society. And these patients, even though they have a very, very simple congenital heart disease, we can see in our national registries that they are underrepresented in the workforce. On the left side, you see the ones who have an ASD, and on the right side, you see the ones who have no congenital heart disease. And you can see the red ones are the ones who are not working at the age of 30 years. And this is quite depressing to look at. If we then take into consideration how many of these had a psychiatric disorder, you can see it's actually quite a lot of them who are also burdened by psychiatric disorder. So we don't know if they don't have a job because of the psychiatric disorder or because of problems with their ASD or because of an underlying genetic syndrome or other things. But we can just count the numbers and see that this is a problem. No. If you do not work in Denmark, you will be on social benefits. And from the register, we can see how many people are on permanent social benefits. And here you can see again our ASD cohort, that is a lot more who are on permanent social benefits in this group of patients. And it's not because they're lazy or they try to avoid getting to work. Many of these patients, they actually make a huge effort to try to fit into the workforce somewhere. And there's a lot of efforts to try to make them fit in, try to find the place where they can actually fulfill a job. So. Good. VSD, you see the same. Also a group of patients we would think they're pretty normal. They should do well. If they have a VSD and a psychiatric disorder, the risk for being on permanent social benefits is very high. And you can also see it increases with age. So it's something we need to look at, some patient group we need to look further into because they have a problem that many of us haven't recognized before. So we know that in Denmark, it's very difficult to get a psychiatric diagnosis. It has been because a lot of people felt it was stigmatizing to be given a psychiatric diagnosis. So we know for sure that a lot of people don't have a diagnosis despite having a psychiatric problem. So what we're doing now is trying to find, the real number by sending out surveys to all patients and families where the patient is less than 18 years of age, and then ask them with some validated questionnaires about psychiatric burden and how much help they have received. And we can see we're still gathering these data, but we can see that there's a much higher burden, and we can also see that in Denmark we are very bad at helping them. I know here you have a beautiful neurodevelopmental clinic and are making an effort to try to help these patients. We are far from that in Denmark. We really had to work on that. Good. So the national registries. Some of you may now think, how do we get access to all these, you could say, kind of private data? And how far back does these registries go? Our registries are very old. There are many different registries, but the first ones are very old, more than 100 years old. For many years, we were registered in state churches when we were born and died, and then other registries have come later on. And so they basically date far back. But just to let you know, they do not date as far back as the time when we got our national flag. So now you have to hear a little bit of Danish history. Denmark, the king in 1219 was Valdemar II. He was fighting against the Baltics, and they were not doing very well. The Danes were defeated. They lost hope. They were really not having a good time. And then suddenly, when they thought everything was lost, then the flag fell down from the sky. June 15th, 1219, Dannebrog, our flag, fell down from the sky, and that instilled courage in all the Danes, and they won the war. And since then, we've had this flag. So, yeah. So our registries are not that old, but they are old. And in 1968, it all went electronic based on each of us having a central personal registration number. And this number is something we're given when we are born or when somebody immigrates to Denmark. Also, if we have patients we operate from outside, they get a Danish central registration number, and everything is linked to that number. If I go and open a bank account, I have to tell my number. If I get a job, I need to tell the number to get a salary. If I go to the dentist, if I want a passport, if I need a driver's license, if I want work benefits, if I go to school, so my children, they have been using their number when they went to kindergarten, to school, to university, everything. So basically, it's very, very difficult to function in Denmark without this number. And then we use this number to combine all the information from the different registries. So if you are a licensed researcher, then you can ask for the possibility to combine different registries. Then you send your application. Let's say I would like to look at psychiatric burden in these patients with congenital heart disease. Then there will be a statistician who would combine the different registries. And then I'll be given back the big data set without these numbers. So I will never be able to identify the individual patient. I can only look at like groups of patients. So this is the way it works. So for instance, for the ASD and VSDs, we would look data from different types of registries and then talk about and then make get our knowledge from that. Good. So one thing is to get a job, another thing is education. And I would like to talk a little bit about education because there I can also show you an example of some of the pitfalls, some of the problems there are in using registry data for science, because they're not made for science, they're made for administrative purposes. So it's quite easy to kind of use the registers in the wrong way. Pitfalls. So one thing we started out with was there has been a link between this size of head and educational performance or neurodevelopmental outcome. So if you have a very small head, it's linked to having educational problems. So we thought, maybe we could look at the head circumference on children born with congenital heart disease in Denmark. So we looked at 1 million live-born infants and looked at the different types of congenital heart disease to see how is the head circumference in these groups of patients. So the midwife will measure the head in all babies in Denmark when they're born. So what you can see from here is that the line is the C-score, which is, you could say, the normal. If it's on the left side, it's a small head. If it's on the right side, it's a large head. None of the congenital heart disease patients as groups have a large head, but quite a few of them have a smaller head than normal. For each congenital heart disease, you would also be able to see that there is, besides the size of the head, it's also the birth weight. And this was in order to see if is it a symmetrical growth retardation or is it an asymmetrical? And if you look at the transposition of the great arteries, you may be able to see that they have a small head, but they have a they have a normal birth weight. So this specific congenital heart disease seems to be an asymmetrical growth retardation. So from personal experience, I know that a small head is not hindering you in getting a medical education and become a cardiac surgeon. So I don't think we should just, well, then now we come to the thing when we want to look at more than just size of the head, but actually what impact does congenital heart disease has on educational level. So we looked into the registries that will capture data on all the national tests that are made in Denmark. Every second year, every child in Denmark has to go through a test, no matter whether they are homeschooled or on a public school or a private school. So they will go through testing in Danish, math, and other things. But here I'll just show you the Danish and the math gradings that they will undergo every second year. And if we take these scales that go from 1, which is poor, to 6 is excellent, you can see congenital heart disease is on average 0.1 grade below the background population. And I think most of you would agree with me, that's not a problem. I mean, it's not a problem that your child has a 0.1 grade lower than somebody else. It's not really a huge issue. The problem is here that quite a few of these patients with congenital heart disease, they are exempt from testing. So for some reason, they don't even participate in testing because the parents say, or the doctors say, or the school teachers say they are not capable of participating in testing. And if you look at children who receive special education, 30% will be exempt from testing amongst the congenital heart disease patients. And this is something you only know if you really dig into these registries and try to understand how they're built. Because if you just like take it for granted, what's coming from this registry, then you can make completely wrong conclusions. So there's a big problem with knowledge in our registries that you you need to know the history and the buildup of the registries to really understand what's going on. So with a lot of other things, garbage in, garbage out. It's not any better than the data you put in. And I know, for instance, that the diagnosis of a congenital heart disease, the way it works in Denmark is that it's very often the junior doctor who's making the discharge summary. And I remember from when I was a very junior doctor, I didn't even know I wanted to go into cardiac surgery. I know how I was sitting there after a long on-call, tired, and had to do these discharge summaries. And I can assure you, I've made a lot of mistakes in this. And all these mistakes, they go directly into this registry. So you have to be very careful when you look at these registries to figure out how can we use them without making a lot of mistakes here. So there's problems with validation. We have validated in our studies, we've validated all patients who have an ASD and a VSD, and we found that 30% of those who had a diagnosis in the registry, they did not have the diagnosis in real life. It was a mistake. We have a selection bias. There are missing data. You have to consider how are you going to treat patients who are adopted. It can be a problem if you're going to look at maternal fetal environment. You don't know anything about it. What about syndromes? How do we deal with that? Multiple pregnancies. Different registries are started at different times. But if you just make the request for the statisticians to find all the data, you will not get the knowledge about that this registry was not started until 1979. So basically the first part of your data, it doesn't make sense. So lots of problems with this. And just to give you an example, we started out with when we wanted to look at the impact of maternal fetal environment on our patients, we started out with 16,000 patients if we just took the raw data from the registries. And then we cleaned up the data with taking into consideration all these things. And we ended up with a cohort of 7,000 patients. So this is just to tell you that don't believe everything you read about these registries. There tends to be some of the journals are really excited about these registry data. And it's great for a lot of purposes, but there are a lot of registry data out there that if you know how these registries are made, you can see it's nonsense, some of it. So be careful when you read data from registries. Good. With that, I would like to tell you that not all is bad in congenital heart disease. There are some enlightening aspects that we have also found when we did all these registry data. So for instance, if we look at risk of suicide in this cohort of patients, it's not enlarged. To have a congenital heart disease, despite having lots of problems and psychiatric issues, they do not commit suicide more often than the background population. The hazard ratio is 0.8, actually pointing towards a lower risk, if anything. If we look at self-harm, how often do patients with congenital heart disease commit self-harm? And you can see that the curves here over years is showing the red curve is the congenital heart disease patient, and the blue is the background population, and there's basically no difference between it. So they have the same risk. We've also tried to look at fertility, reproduction, because it's a natural wish for these patients when they grow older. So many of them want to have a family, they want to have kids. And of course, if you're born with a chronic disease, you may ask yourself, am I able at all to become pregnant? Am I able to make my partner pregnant? Do my kids have congenital heart disease more often than the rest? So using the registry, we looked into how many patients would seek help for infertility. So in Denmark, infertility is a huge problem. We produce less children than we should, and the government is now giving extra money so we can have fertility help. I think they should rather give us some money to have taking care of those children who are already born. I mean, better schools and stuff like that. But that's my personal opinion. Right now, you can get help with the infertility. So we have very good data on who is seeking infertility, and it's free. So here you can see women have a hazard ratio which is basically about 1, indicating that there are just as many who seek help for infertility among the congenital heart disease as the background population. So it looks as if, like a general thing, that you do not become infertile because you have a congenital heart disease. There may be, of course, specific cases where you have very complex patients who do not fall into the group. Another way to look at it is to see how many kids do they get when they get kids, these patients and background population. And here you can see individuals born who are childless, and the women, it's about 20% if they have no congenital heart disease, and higher if they have congenital heart disease, and the same for men. So you can basically say that there are less patients with congenital heart disease who have children. Maybe because they don't want to have children, maybe because their doctors told them they should not have children, or maybe they have problems finding a partner. We don't know that. We can just see that there are fewer who have kids, but we can see that those who decide to have kids, they have the same number of kids as the rest of us. On average, you have 2 kids in Denmark per person. We can try to divide it into some of the simple and complex congenital heart diseases, but you can see the numbers become very small. But you can also maybe see that the number of kids doesn't change very much. So I don't think we should use our registry to dig into this detail so that we can talk about univentricular hearts or whatever, because we don't have that many. In Denmark, we have altogether 250 patients with univentricular heart. So it's, again, remember, tiny country. So then you may also read some papers that try to use registry data to explain mechanisms behind by using very sophisticated statistics, which is good, and there's nothing wrong with it. It's just you have to remember still that these data are not made for research purpose. They're still, it's garbage in, garbage out. And when you try to use it to explain some mechanisms behind, you may also run into problems. But for sure, you can see sometimes that there's an association between things. So here we looked at neurodevelopmental outcome, which means does these patients have diagnosis of HTSD, autism spectrum diseases, or tic disorders more often than the background population. And then we divided them into those who had a congenital heart disease and also those whose mother had preeclampsia, because there are now indications that the placenta is heavily involved in some of the long-term outcomes. So we looked at the combination of having a mother with preeclampsia and then the child having a congenital heart disease. And here you can see that it seems to be a high risk to have this combination. They have many more neurodevelopmental issues than the rest of the group that either only had a congenital heart disease or only had preeclampsia. So this is kind of a way to say that there may be an association, there may be a mechanism, but again, the registries cannot tell you that that is actually the case. You have to do other studies to answer those questions. So now have been through a little bit about what we use our registries for. And I think you could use the registries for all kinds of children with liver diseases, children with asthma. You could basically apply the same framework on all of them. And you can get some interesting results, but you can also get out in deep problems if you try to overinterpret the data and if you don't know how the data are created. So with that, I would like to once again say thank you for the opportunity to come here and talk and show you a picture from my summer house, where the west coast of Denmark. So thank you very much.